I am very, very happy to have our next speaker with us. After Would you speak in 20? It was the second one, 2015. So it's the return. um, so Dr. Julie Regan is an associate professor at Texas State University. She is, and apparently she got nervous when I said this, but she is the foremost expert in the country on state laws related to C. diff and other healthcare associated infections. And she has just updated her research after 10 years. And she is going to tell us what she has learned in the past 10 years. And thank you, Julie, so much for being here.
Thank you, everyone. Okay, so are we working? Can you hear me okay? All right. So first of all, just want to tell you a little bit about my background. I'm actually at New Mexico State University. I move around a lot, so it's hard to keep up with me. So I'm, by training, I have both a law degree and a PhD. And so, you know, I started out as an attorney and I worked for over 25 years, had a career in law, and actually became interested in the topic of healthcare associated infections when I was asked to serve on an advisory committee in 2008 in New Mexico. So that's how I got started. Then I always wanted to get my PhD. And so after about 25 years practicing law, then I moved into academia. So my last job practicing law was as Deputy General Counsel at the New Mexico Department of Health. And that's where I served on the advisory committee. And I served on state and federal advisory committee and had a lot of input into policy development for state public reporting laws of healthcare associated infections. So that's my background. And of course, now I teach public health law in academia. I teach mainly public health students, but also students in healthcare administration. And so I always incorporate my policy experience on healthcare associated infections. So that's my background. Before I get started with my speech, I want to introduce you to my father. We all have family members who we've lost along the way, and he passed away in 2019, thankfully before the pandemic. But his end-of-life care was complicated by a C. diff infection. So up until this time, I wasn't personally touched by C. diff, but eventually I was. So I have a lot of background for you. For those of you who have been in this field for a while, you know a lot of this is going to be a review. For many of you who are survivors of C. diff, or some of you who haven't been in this realm for a while, this is going to be an introduction. So for those of you with experience, I apologize. Bear with me for a little while we get some of this background information. Okay. So I originally was going to present with a 10-year review because that has such a nice ring to it. But as I was researching this and preparing for my speech, I realized that so much would be left out if I just did a 10-year review. So we're going to actually go back to 2008. In 2008, the word was quickly spreading that HAIs were known to be significant contributors to morbidity and mortality. These were the stats that were being thrown around at this time. Every time you picked up a publication, you usually saw these stats that 1 out of every 20 hospitalized patients would contract an HAI, 1.7 million HAIs occurring in the US every year, resulting in approximately 99,000 deaths. Now, those have changed, of course, since then, but those were the 2008 stats. The financial cost was also staggering, but most importantly, there was growing evidence that HAIs were preventable through proven practices. So that was the message at the time. So in response to this message and the advocacy efforts that were being led at the time, the state legislatures started enacting what are known as state HAI public reporting laws. There were a handful in 2004, and by 2008, so very quickly, by 2008, we had 23 states with these public reporting laws. So what is a public reporting law? So generally speaking, these are surveillance and public reporting. You have those two components. The law, whether it's a statute, an administrative rule, or some other type of authoritative directive, will dictate the facilities that are required to report and then the specific healthcare associated infections that have to be reported by those facilities. Now, under the surveillance part of the law, data on healthcare associated infections is submitted to the state by the specific healthcare entities subject to the law. And then the state gets that data and will analyze it, do a risk adjustment, and then will release that information or reports to the public. And depending on the state, those reports may or may not contain facility identifiers. Then that publicly released information would detail the actual rates so that the public or consumers could use that information to make their own healthcare choices about which facilities they would want to, for example, have a surgery. And then the information is also used by state officials to design prevention programs, intervene with training if it was needed to reduce or prevent HAI, and then to set policy for future efforts. So at this time, there were 4 main healthcare-associated infections that were typically required to be reported by these early public reporting laws. So those were central line-associated bloodstream infections, or CLABSIs, surgical site infections, catheter-associated urinary tract infections, and ventilator-associated pneumonia. A lot of attention was also given to MRSA, because after all, these central line associated bloodstream infections, the ones that ended up being fatal, usually had a MRSA as the infection causing the infection. But C. diff really wasn't on the agenda yet. In those early public reporting laws, there was some talk about it, but really most of the attention was on CLABSIs. From 2008 to 2010, in addition to the state HAI public reporting laws that were being enacted by the state legislatures, some states had also begun to prepare what are known as these HAI programs within, like, the state departments of health to address these issues. And these programs would provide training to facilities, address the surveillance data that was coming in, and try to prevent HAIs. Now, these programs would work in tandem with the HAI public reporting laws, and in many cases, the law would actually dictate that the state had to create a program. But many of these programs were struggling due to financial concerns. So after all, this was 2007, 2008, when the US financial crisis hit. And this had a big impact on the state departments of health and also on the development of HII programs, because after all, these were new programs. You had to hire people, you had to develop policy, you had to purchase furniture. They were very expensive. You had to have an epidemiologist. You know, they were very expensive programs, and many of these states simply didn't have the money to fund them. So, for example, Arkansas had an early HAI statute that had a provision in the law that said the development of state HAI program would not be initiated unless and until they received funding. California was another state that had financial issues at this time that hindered the development of its program, and many other states likewise suffered. So here come the feds to the rescue. Through the Department of Health and Human Services and the CDC, the federal government started to play a major role in the control and prevention of HAIs. First, federal funding was provided to the states through various federal laws. We had, of course, the Affordable Care Act provided a lot of funding, but there were other federal laws as well. State planning efforts were supported by the CDC through what is known as the National Action Plan to Prevent HAIs. And to receive this federal funding, a lot of states had to create their own action plan where they detailed how they were going to go about addressing HAIs in their states. So this federal funding and planning opportunity provided support to all 50 states, DC, and some U.S. territories. CMS also launched its hospital inpatient quality reporting program in 2010. Now, data wasn't required to be reported yet, but it was starting to ramp up in 2010. Then around the period of 2008 to 2009, when all this federal activity of HAIs was happening, the CDC realized that there was a strong need for a central national electronic mechanism to collect HAI data. So the CDC started promoting the use of what is known as the National Healthcare Safety Network, or NHSN, for reporting this HAI data. And that was a very important step. A lot of the states at this time were really struggling with this. And in fact, some of them were still using paper records. So you remember 2008 was about the time when there was a big push for electronic medical records. So this change to an electronic mechanism was a big step. Now, due to all this federal activity, funding, guidance, all states, as of 2010, had either initially implemented their state HAI programs or were starting to implement them. And then running concurrently with the development of those state HAI programs, there was an increase in the number of states that enacted state HAI public reporting laws. So all states had programs in 2010, some states had laws, and then those states that did not have laws were relying on the facilities to voluntarily report data. All right, 2010 was an important year. Over the years, 2008 to 2010, I was closely monitoring HAI public reporting laws, and in fact, it was the topic of my PhD dissertation. So that was the year that I graduated. The dissertation was a comparative analysis of state HAI public reporting laws throughout the nation. So I reviewed the HAI programs and laws of the 50 US states, DC, and Puerto Rico. And it was also about this time that I got a call from this guy named Christian Lillis. And as you all know, Christian and Liam's mother had passed away in April of 2010 from sepsis resulting from a C. diff infection. So somehow Christian found out about my HAI research. I don't exactly remember how, but he called me to discuss how we could collaborate. And that was a very long conversation that day. I think we were on the phone for like 2 or 3 hours. And it was really a turning point for me to focus more on C. diff as compared to just HAIs. So never underestimate the power of a simple phone call. So now frame in your mind, we're at 2010, and these were my 2010 dissertation findings. Because of all the federal guidance and funding I spoke of earlier, all US states and some territories now had programs within state government to manage HAI surveillance, reporting, and prevention efforts. Most of these states had started in 2009 or 2010 when all the federal funding and guidance was coming about. And the CDC was really proactive at this time. They really were reaching out with all the state departments of health and their epidemiology departments. And, there were a couple of states at the time that were kind of holding back, and the CDC was very proactive in getting them to move along. There were a wide range of facilities required to report, the number of states with HAI laws also increased. So all states had programs, but then there were an increased number of states that had HAI laws. So as of January 2010, there were 34 states that now had an HAI public reporting law applicable to reporting HAIs. So there were a wide range of facilities required to report under these laws. However, all 34 did target acute care hospitals because after all, they were really looking primarily at CLABSIs. And so of course you wanted to encompass hospitals. There was a lot of variation in the type of data collection system used, and at this time, only 23 states were using NHSN for reporting their data. Some states still required a reporting using some additional state system, so a lot of variation there. But where you really saw a lot of variation was in the reportable infections. So those initial statutes focused on CLABSIs, surgical site infections, ventilator-associated pneumonia, catheter-associated urinary tract infections, MDRO infections, but last on the list was C. diff. There were only a few states that focused on C. diff. So now let's focus a little bit more on C. diff. And in 2013, I led research focusing on the state public reporting requirements, specifically focusing on C. diff. That research was published in 2015. So anytime you have data collection in a paper that you're publishing, there's a delay because of the publishing of that journal. So just keep in mind that we're looking here at 2013. So we looked at HAI public reporting laws as of July 1st, 2013 to identify C. diff reporting mandates. We found that C. diff reporting mandates had indeed increased, and at this time, more states were requiring C. diff reporting. And there were three major federal influencers that we surmised were causing this. First, the CDC issued a report back in 2012 that drew attention to C. diff incidence rates, mortality, and the associated medical cost. So that one was really important. Next, the National Action Plan that I referred to earlier set C. diff hospitalization and infections as national target measures to be reviewed on an annual basis. And it was noted in the action by the CDC that C. diff reduction improvements had not been as forthcoming as they had hoped for. C. diff data was also starting to be collected on the federal level as part of the CMS Hospital Inpatient Quality Reporting Program. So for those facilities that are hospitals that were Medicare certified, they were starting to report data as of June 2013. And of course, that program required reporting of C. diff. So these were our findings. As of July 1st, 2013, there were 20 states that mandated the reporting of C. diff. So those were the numbers as of 2013. In 11 of the 20 states with reporting mandates, C. diff reporting was independently mandated under a standalone state law. And what I mean by that is that they weren't incorporating any of the federal requirements. It was solely a state mandate. And alternatively, in the remaining 9 states, C. diff reporting was mandated by the adoption or the incorporation of some federal reporting requirement. So basically how that looks in that state statute is they will just incorporate text that says, we are adopting Medicare reporting requirements. And then the facilities in the state have to report those infections as mandated under the federal law. So our research showed that state mandates had gradually increased from 2008 to 2013. The first effort began in 2008 with 2 states. 2 states followed in 2009, 1 in 2010, 1 state in 2011. So you can see they're starting to trickle in. States are starting to get the message, and state legislatures were passing these mandates. And then we had 4 states in 2012. So you had a gradual progression of enactment of these laws. But then 2013 happened. This is when the federal requirements came into effect. So the largest increase was made in the first half of 2013 with 10 new states. And we surmise that that increase in the number of states mandating C. diff in 2012 through 2013 was partially due to the release of that earlier CDC 2012 report calling a lot of attention to C. diff. But then also It was heavily influenced by the CMS Inpatient Quality Reporting Program's C. diff requirements that became mandatory on January 1st, 2013, and that impacted those states that were then starting to incorporate those federal requirements. So in 2013, 9 of those 10 states were adopting those federal requirements. So now let's talk about what's happening in 2022, or what kind of progress we've seen. So I'm currently in the process of updating all this research. It is in progress, so that research is still ongoing. It will be based on a review as of July 1st, 2022, and that date is important. State legislative sessions are typically held in the spring, and they usually adjourn in May or June. So I usually like to wait until to see, for whatever year I'm researching, I want to see if anything new is going to come out of the state legislatures. And then also I like to allow a little bit of time so the executive branch of government can then implement those laws. So that would be the State Department of Health. So I like to have a cutoff date of July 1st in order to allow for that. So that's where I'm currently waiting on that cutoff date. The methodology I'm using is very similar to that I used for the 2013 data and the 2015 publication. So I'm looking at state statutes and administrative regulations that specifically identify C. diff in their public reporting laws. And I do this by searching 2 main legal databases. So you may have heard of these. Westlaw is the primary one that I use, and then also LexisNexis or Nexus Uni. And this can be a really daunting task, and this is where my OCD really comes into play. Because as you know, the name of C. diff, used for C. diff, has gone through several iterations. And so these laws will have all these various terms. And in many cases, they have misspelled it. And so I actually have to use misspellings in my search terminology. So I do all that research on the legal databases. That's just a lot of me in my office just sitting there plugging away. And then once I get that data, then I go to the state departments of health, HAI website, and I try to confirm what I've found. That's daunting as well. Some states have really good HAI websites and some do not. Some don't have much at all. Some of them just refer you to the federal CDC website. And then finally, the HAI program managers of each state will need to be contacted to do a final confirmation of that data. And that's just a verification and accuracy data validation check. So where I am right now, I've completed steps 1 and 2. I've done the legal research. I've confirmed with the HAI databases from the state websites. Now I just need to confirm with the HAI program managers and do one more search right before July 1st to finalize it. One of the big problems that I've seen as a policy expert with C. diff is that sometimes these C. diff reporting mandates won't actually show up in the statute or the administrative regulation. And instead it will be in some maybe a letter to the facilities or maybe a website posting, and then they'll refer back to the main HAI public reporting law. And this has been particularly true with C. diff, where they'll just send a letter to facilities saying, oh, by the way, this year you need to start collecting C. diff data. So that's why it's important for this last final step. But so while this research is still currently ongoing, I can give you a sneak peek into what I'm finding. I do feel like it's fairly accurate. I just need to confirm it with the HAI program managers. So with public reporting laws for healthcare associated infections in general, and here we're focusing on those infections that are acquired in the healthcare facility, there are several different possibilities to consider of how this might show up in the HAI public reporting law. First, a facility might be required to report HAIs based on a federal law if they're a Medicare certified facility, or a state law provision. So they might be subject to both. It just depends on the type of facility. If it is a Medicare certified facility, then it will have to report HAIs under the CMS Hospital Inpatient Quality reporting program if it's a hospital. If it's not a hospital, under other facility reporting programs. And we're going to look at those closer in a minute. But of course, my research is about state reporting mandates. And so this is where you really see a big variation in how it presents on the laws. So the state might incorporate the federal reporting requirements. That's what I'm seeing. It might do this generally. It might just say, this, you know, if you're a hospital, you have to report those infections are required to be reported by the CMS Medicare rules. Or the state might say, yeah, you're going to follow the CMS Medicare rules, but only for these specific infections. And then you may have a standalone provision without a federal incorporation. If it does only mandate certain infections, they'll give a list. They'll say, follow the Medicare rules, but only for these infections. Then I have to dig a little bit further to make sure C. diff is on that list. And then finally, considering community-acquired or population-based C. diff infections, so not related to the healthcare facility, the state may include C. diff on its notifiable diseases list. And those are diseases that are reported on a regular basis, you know, things like HIV/AIDS, rabies, Zika, all these other conditions of significant importance that are required to be reported by the state. So C. diff is starting to show up on those lists. So here are the federal reporting requirements that include C. diff reporting mandates. So these are federal, and these are the types of provisions that may be incorporated into the state law. If the facility is a Medicare certified acute care hospital, then it has to report data under the CMS hospital inpatient quality reporting requirements. Those started in 2013. Federal reporting requirements for inpatient rehabilitation facilities began in 2015, long-term care hospitals in 2015, and then finally some cancer hospitals began in 2016. And all of these mandates, these federal mandates include reporting of C. diff lab ID events facility-wide. And then they also have to use NHSN. So remember, that's the Federal Electronic HAI Data Tracking System I mentioned before. Now here's where it gets interesting, turning back to the state HAI mandates. So as a starting point, there are now 37 states that mandate, that require healthcare facilities to report their HAI data to NHSN. So this is actually a screenshot of the CDC's website. I have gone through all the state laws to confirm this. And so, yeah, so now we have 37 states that are requiring states to report their HAI data to NHSN, which, remember, as I mentioned, is a federal electronic tracking system. And now let's look a little bit closer at some of these state laws and how the text is actually written for these mandates. So this is an example from North Carolina. This is in an administrative rule. It requires facilities, hospitals are the facilities required to report data. They have to use NHSN as their reporting that data. They have to make the data available to the state. So there's actually an agreement that the facilities have to sign with the CDC. It's called a data use agreement that allows the CDC to then share the data that's been reported back to the state. So as before, where the data would be reported directly to the state, now it's a two-step system. It goes from the facility to NHSN and then back to the state. Also in North Carolina, this is an example where they have to report HAIs that are reportable under the CMS federal regulations for hospital. And now you can see in this text that it doesn't mention C. diff. So this is an example of a state law that generally incorporates the federal reporting requirements. And you can assume that it includes C. diff because C. diff is required under the federal regulation. But then I go to the website to confirm that. Here's an example from New Mexico. Of course, this is where I have my history of policy development. So in New Mexico, instead of relying on just a general statement about adopting federal requirements, New Mexico says we're going to adopt the federal requirements, but only for 2 infections. And those are CLABSIs and C. diff. And historically, those are the 2 infections that have been reportable in New Mexico. So that's an example of a state that lists only specific infections. Another one from Texas. In Texas, a healthcare facility, which is defined as a general hospital or an ambulatory surgical center, has to report data to the NHSN, must make that information available to the state. And the HAIs that are reportable are those under the Medicare program. So again, the law doesn't specifically list C. diff, but you can presume that it's required. And finally, because we're in DC, I threw in a DC example. DC requires more facilities to report than most states. Most states focus on hospitals. DC focuses on acute care hospitals, ambulatory centers, long-term acute care, skilled nursing, and outpatient renal dialysis facilities. So this is a state where you're going to have some of those other federal reporting requirements come into play. And here DC does give a specific list of infections and does include C. diff, which we like. Now, there are a couple of states that have refused to follow suit. They have adopted the federal NHSN reporting requirements, but they don't require C. diff reporting. So this is a screenshot from Missouri. This is from their frequently asked questions page, and this is the only item on that frequently asked questions page. So it's just one question. Why aren't you requiring the reporting of MDROs and C. diff? And this was their answer. So the other state, I still have to confirm this, but Oklahoma requires NHSN reporting, does give a specified list of infections, but it did not include C. diff. So I have to confirm that one. So this is what you've all been waiting. This is a snapshot of where we are now. And Christian hasn't seen this. So this table gives you a comparison of my data. So 2010, my dissertation findings, my previous C. diff reporting mandates paper, which was 2013 data, and now my preliminary data. And remember that this is draft. I still need to confirm this, but this is what I found as of 2022. So in 2010, there were 5 states that required C. diff reporting. Those reporting mandates were all found in state laws that did not incorporate federal reporting requirements because they really didn't exist then. In 2013, there was not only an increase in the number of states requiring C. diff reporting, but states were starting to require NHSN reporting and or incorporate these federal reporting requirements. So that was a big jump. A total of 20 states required C. diff reporting at that time. 11 had standalone laws, and 9 had the federal reporting requirements incorporated. But in 2022, according to my draft data, there are 34 states now with C. diff reporting mandates. There aren't any states remaining that have just a standalone state data reporting requirements. They have now all incorporated some form of a federal requirement. So it might be simply just a requirement to use NHSN definitions, methodologies, and protocols. It might be an incorporation of the CMS inpatient quality reporting requirements for hospitals, or it may extend to some of these other federal reporting requirements for these other types of facilities. So there's just a lot of variation. When I first started seeing the incorporation of the federal requirements, I thought, oh gosh, this is going to make my research so much easier because we're going to have consistency. But instead, they're adopting the federal regulations, but then applying all this variation. So there's variation as far as the facilities that are required to report, as well as the types of infections that are reportable. So this is what we have for 2022. According to my draft, again, this is preliminary draft data, 34 states with reporting mandates. That's a huge increase. That's a majority of states. And I'm really proud and excited to see that. So that's healthcare associated infections. And now let's look at community acquired infections. I didn't look at community acquired infections in that earlier 2013 research, so I don't have a point of comparison. But according to my current research, I find 7 states that now require reporting of community acquired infections. So I think now this is our next stage that we need to attack, is to get more states that list C. diff on their notifiable diseases list. Incorporates it. And then in addition, this isn't a mandate, but this is another federal influencer. The CDC has a C. diff infection surveillance program that is population-based. These are not state mandates again, but I've included it here because it's applicable to community-acquired reporting. So this surveillance program is operated through the CDC's Emerging Infections Program. The data reported for this program is used to measure the burden of C. diff in the population, characterize different strains, and monitor trends over time. So this is really a positive movement. This one was launched in 2009. So again, during that time period when we started to see a lot of federal activity. It started with 7 sites. It now currently has 10 states that have been reporting data since 2011. So that's a really positive movement. All right, so that's our current status, and I'll be happy to answer any questions.
Thank you. Julie, that was phenomenal work.
Oh,
I can
thank you.
appreciate the hours that went into all of your years of research. So I'm curious, 34 states now are reporting. What do you think is the reason the other states are not? Is it lack of funding in the public health department to do this, which is very labor intensive? What are your
Right.
thoughts on that?
So we were starting to see major movement, around 2013, and then we had the adoption of the use of NHSN. So there are 37 states using NHSN. So only 2 of those states are not reporting C. diff data, according to what I can find. So I think the answer is that the same problem that's plagued HAI programs from the very beginning. There have been some states that have just been slow to get on board. A lot of it is funding. A lot of the states that do not require HAI public reporting, including C. diff, are those states that struggled from the very beginning in forming their HAI programs and relied on voluntary participation. And in my experience as an attorney and working for the state, hospitals just aren't going to report data that is not mandated to be reported. And so I think you see a time lag. So, and now there has been such a transition into incorporating these federal requirements. So in the policy world, what we refer to this as cooperative federalism, where something may start with, really a state policy development, and then the federal government becomes involved and provides funding and support. And then the states then kind of back off because the federal government really has control of it. So even though these are state mandates, the federal government really has a large role to play in the progression of how it moves. So since that time, I've really seen states backing off. Great question. Thank you.
Julie, that was a tremendous presentation, first off. Thank you so much for that.
You.
A quick question. So the Peggy Lillis Foundation is pursuing this year in our advocacy work to encourage the CDC to make C. diff a nationally notifiable disease, which, as you know, is a cooperative arrangement between the CDC and the state and territorial health officials and other local folks. How do you see that connecting to some of the work that you've done, around the community-based surveillance activity, which obviously is fairly limited now and it's less than 10 states?
So anytime you have policy development, it has to go through a progression. You have to have agenda setting. You have to have movement coming from advocacy organizations and individuals who are affected by it. And sadly, that boils down to funding. the advocacy organizations really need to have sufficient funding support in order to get that message then to legislatures and their individual legislators in their state, and also to start putting pressure on the CDC, because after all, how this began in the beginning with the movement, the progression of HAI public reporting was that individuals who were had family members who were dying of CLABSIs. It was just a horrific, a MRSA infection with a central line associated bloodstream infection. They were putting pressure because there weren't strong advocacy organizations at that time. They were putting pressure on their individual legislators to introduce legislation. So it all starts with the grassroots advocacy efforts to draw attention to the need. And I think we've got a good start, because I am seeing an increase in the number of states that are including it on their notifiable diseases list. We have, of course, PLF's efforts in that, and the CDC is already collecting that data from these 11 states now, going back to 2011. So what I'm really hoping is that sometime soon, when we get some relief from COVID, from the pandemic, that the CDC will come back and draw attention again to C. diff by issuing a report on their findings from these emerging infections program, to report that notifiable disease data. Thank you. Thank you for your question.
Julie, thank you for your presentation. My name is Jody Lee. I'm from Tech Lab. And my question is that the NHSN currently is the data source for the value-based purchasing programs that CMS runs. So what is happening with the other states that are not reporting to the NHSN? Are they not participatory in the value-based purchasing programs?
Those again are going to be the states without HAI public reporting laws. So they're not going to have a state mandate requiring facilities to report, and they rely on voluntary participation. And so you would have to go into, each state has its action plan that they created in order to get that early funding. And many states have kept those plans updated. And so they would need to describe in those plans, what efforts they are using to, for prevention efforts, surveillance, and so on. Again, it's the issue that's going back to from the very beginning. They've just been slow to adopt standards, and they're probably relying on some electronic state system. I'm not sure. I don't really have the data on that. I don't track. It's really hard to track voluntary efforts. Of course, I'm looking at mandates. That's something that is directly in a state law. And so it's hard to understand exactly, without doing a survey, to understand exactly what is going on in those states. But I would assume it's the same problem from the very beginning: a lack of funding, a lack of attention, and voluntary participation by the facilities.
Hi, thank you so much. I have a couple of questions.
Okay.
One of them goes back to the idea that CMS had rules about non-payment to hospitals for preventable hospital-acquired conditions. Do you think that's still a factor in? Okay, so I'm moving on.
I think from the very beginning, I don't think it's had a huge impact.
Okay.
I think it's the public attention really that gets, and that's just my opinion.
Okay, I just wanted to get that one out of the way.
Mhm.
But my real question comes down to the fact that I'm somebody who was diagnosed in an emergency room, not as an inpatient. Do those type of diagnoses make the grade for reporting? Because a lot of the standards require certain, long-term acute care hospitals, inpatient rehab facilities, but an ER or a private practitioner who diagnoses C. diff,
Mm-hmm.
there's no required reporting. How does that come together? How does that factor in with this mandate? on a state level. Like if I go to my gastroenterologist because the hospital does a PCR test, which they say, we're not so sure, that's a very sensitive test, you may or may not have it, you should follow up with your gastroenterologist. So the private practitioner then confirms that it's C. diff. He's not a mandated reporter because
No.
he's not a hospital. So how do we include those numbers, in your opinion, so that we get an accurate count?
I think, again, it's going to come back to the notifiable conditions for community acquired, because that's going to catch everything. And then if the state has on their form, if it has an area where they can note, whether this infection was contracted in a facility or in the community, I think that's going to be the best all the way around. Because you're right, a lot of times patients, may just be diagnosed with diarrhea. And then they're sent back to their primary care provider or a gastroenterologist. And unless you're in one of these 7 states that have notifiable conditions reporting, it's not going to get reported. So I think really that's the key for the next level of attention.
Well, thankfully, there's an amazing nonprofit organization that's working to make C. diff a nationally notifiable disease. So this is going to be our last question for Julie, and then we'll have our next panel.
Hi, thank you, Julie.
Hi.
So my question actually is very similar to the one that was just asked about people who are diagnosed in a doctor's office. So of the 37 states you mentioned that do include C. diff reporting, right now that is just for healthcare
It's just for healthcare facilities. And again, a huge variation in the facilities that are required to report. You can generally assume hospitals are on the list, but then it varies from there.
So right now, there isn't anything about just general population spread.
Except for in
reporting.
those 7 states. And even in those 7 states, there are only certain counties.
Wow.
It's not the entire state.
Wow.
So that's,
And were the 7 states that were in one of your slides?
as far as the actual list, I can tell you.
Wow. So with, and Christian,
So-
you could answer this, with what the foundation is pushing for is for it to cover both healthcare and general population.
Yeah, so so when something is considered a nationally notifiable disease by the Centers for Disease Control, it is mandatorily reported by any place that diagnoses it. A challenge with C. diff, which Jenny actually alluded to, is that we have 2 kinds of tests. One is considered slightly too sensitive. It catches people who are colonized but don't have active disease. The other is considered somewhat not sensitive enough because it may, especially if like you drop off your sample and anyway. So the primary obstacle that we've had up to this point is that there was not a sort of consensus basis of what was considered a diagnosis. But recently there's been an algorithm developed by, I think IDSA and the American Gastroenterological Association. And so what we're asking for in terms of a nationally notifiable disease is for them to count it being diagnosed at that rate. So actually a clinical diagnosis, not a test. The tests obviously both play an important role, but it's really the doctor saying, this is the ICD-9 code for what you have. And hopefully that will solve it.
And so to further answer your question, so these are the 7 states that I have. Again, preliminary data, but I have Colorado, but only in certain areas, not statewide. Kentucky, Massachusetts, Minnesota in some counties, Nebraska, New Mexico in some counties, and Utah.
Thank you, Julie, so much.